Bueno, muy buenos días a todos. La verdad, para la Sociedad Colombiana de Cirugía Plástica Facial y Rheología es un verdadero honor tener a Sebastián Cotofana como invitado hoy en nuestro martes de conversatorio. Sebastián es una persona que ha dedicado gran parte de su trabajo al estudio anatómico y su relación con nuestros procedimientos de inyectables, no inyectables y de cirugía en la cara. Tiene publicaciones escritas sobre todos los temas y hoy vamos a hablar con él 30 minutos y nos va a contar un poco sobre 10 busts de anatomía. Eso es algo que él está haciendo en su cuenta de Instagram y está dando unos tips, unos consejos sobre procedimientos en anatomía y sobre descripciones anatómicas muy cortas, y vamos a tener 10 de estos consejos. Después, si tienen preguntas, por favor, enviarlas al chat que les comentamos, y definitivamente, pues, muchas gracias a Sebastián por estar con nosotros. Sebastian, thank you so much for being here with us. It's a real pleasure to have you. We are really delighted that we can be able to see the 10 anatomy boosts you're going to teach us today. And well, just let you know that Colombia is always going to be your house, and you are invited here as many times as you want. So thank you so much, and let's hear you.
Thank you so much. It's always a pleasure. Honestly, it's and you know what I very much like about this presentation. I never gave it before. I mean, in this whole concept, but I very much like this idea to have short ideas presented in a concise way, and not to continue, just a little bit short boost bit by bit. And it's really a great pleasure to provide and share this knowledge with you guys. So for this, I will share my screen. There we go. I will share my screen. And there we go. So, I think everybody can see that. And let's just get on with the topic for today. So 10 anatomy boosts. Actually, it's quite interesting. You know, I'm thinking about just to reduce all what's new in anatomy just to 10 minutes, but I think it's still doable. And I will just I just pick random any topics. Some of them, actually most of them, are not related to what I did before. It's just random picks to topics that I think might be important and might be of relevance. Of course, I don't have any. The industry does not influence my results, or what I'm presenting here is just based on pure anatomy. So boost number one is the formation of the philtrum, because we know the philtral ridges are different, and the philtrum is very important, how the lip looks like. And to understand this, we need to think about anatomy. We need to think about, in detail, embryology, because when we think about the face, develops here very, very, very early. And what happens is, during embryology, we have the different processes: frontonasal process, maxillary process, and mandibular process. All of them kind of are located in this area here. And you can see that this area here, the lateral nasal prominence, fuses with the medial nasal prominence, and together, when they fuse together, they give rise to the upper lip. So it means this part here and this part here fuses with this part, and the fusion is not in the midline, because the fusion is paramedian. And you can see this very nicely here. And here in this area, you can see that the medial nasal prominence, everything that's yellow, fuses one side with the other side. And then they fuse with the maxillary area here, in this area here. And what happens here in this area, guys, do you also see that someone is writing on the screen here, which I don't very much appreciate? Yeah, just try to check this out, because someone is writing here on the screen, so that might not be something important. So when we continue here in this area, we can see actually that one area here together with the other area here, when they fuse, and what happens with the orbicularis oris muscle is that the muscle from one side crosses over to the other side. And in the area where you have a crossing of one muscle to the other, kind of like this forms the philtral ridges that you can see in this area here. Because here in this area, you have the fusion from one side and a fusion from the other side, which exactly is not in the midline, it's paramedian, which has to do exactly with the embryology in this area. So this is why we have philtral ridges influenced by embryology, and this is why the upper lip looks different than the lower lip, and this is why it's very important to keep these philtral ridges and to understand where they originally come from. Boost number 2. The layers, actually, which I always talk about, the layers, they are not always parallel. This is the funny thing, they're not always parallel. And I want to try to show you this one. So this is how it looks like when I do sometimes my dissections and try to show the layers of the face. Yes, it's a lot of heavy metal. I mean, it's a lot of efforts to dissect all of these layers, but then it looks like this. And of course, this looks a little bit more better. So if you look at this one here, it looks like all the layers are parallel. You have the skin here, you have the smas here, and then you have the deep temporal fascia, which splits up into the parotido-masseteric fascia in this area here. So these are kind of the layers, but these layers are not always parallel. So that means there are exceptions. So if you take the line of ligaments, which separates the medial and the lateral face, then you need to separate the layers of the face based on the two different regions, because the lateral face, there you have layers in parallel. It looks really like an onion, really parallel layers parallel to the skin surface. And this happens here in the lateral face, which we know because we have all of these connections with it, and which are very important later on in the other boosts. So this is parallel layers. But in the medial face, this is not the case, because in the medial face, we have layers that are not parallel, that are a little bit almost even transverse running. And this is due to the fact that the muscles of facial expression, which are running here, are coming from the bone and inserting, kind of going this way. And you can imagine it looks a little bit like this, like roof tiles. So this is actually the basic different concepts between the layers that we have, because I know everybody talks about the layers are everywhere, but actually the layers are a little bit different. Medial face, they're different as compared to lateral face. The clinical relevance for this is when you do a fat grafting into this area, when you perform surgery, when you inject your fillers into this area, the major resulting effect, when you place a filler below these ones, you will increase in volume. You will have a local increase in volume. When you place a filler or fat graft, whatever you do on the lateral face, because the layers are parallel, they all can result in lifting effects. So this is why you have two major aspects, kind of medial face versus the lateral face. So we're coming to Nicola. This is very disturbing if someone is drawing on my screen. So if you go to the next boost number 3, the parotido-masseteric fascia forms the masseteric ligaments. So what does that mean? I mean, how is that working? What is this? So everything starts with a publication kind of by Mendelssohn in the year 2013. And in this year, in 2013, the pre-masseter spaces were introduced in this area. You can see pre-masseter spaces were introduced. And what these pre-masseter spaces actually also included was the fact that you have these spaces here on top of the parotido-masseteric fascia. So this is the floor, and then you have your pre-masseter space. This is the middle pre-masseter space, this is the superior one, and this is the inferior one. So you have kind of 3 pre-masseter spaces. And the anterior boundary of the pre-masseter spaces were said these are the masseteric ligaments. And then there was this image here published, and this image here kind of referred to also this plane or this line of ligaments, but actually it's not really true, because this one here follows a specific line at the anterior boundary of the masseter muscle. And we know that between the mandibular ligament and the anterior boundary of the masseter muscle, there's a certain space. And so this is why this drawing is not absolutely accurate. But what is more accurate is the understanding of the parotido-masseteric fascia. So here you can see the parotido-masseteric fascia, and what the parotido-masseteric fascia does, it bends down, goes deep, and attaches to the buccinator muscle. In this way, it forms the facial vein canal. And the facial nerve branches, which initially run deep to the parotidal masseteric fascia, they change the planes. And when they change the planes, these facial nerve branches, they form adhesions to the overlying SMAPs. And these adhesions that are connected to the buccinator muscle and not to the masseter muscle, these were previously termed the masseteric ligaments. In your dissection, it looks like this. You have your skin, you have your SMAS, and then you have the parotidomasseteric fascia. You can elevate this all at once. And here you can see the further you go at the anterior boundary of your masseter muscle, then you can suddenly see branches of the facial nerve because they travel upwards, they insert into the SMAS, and when they do so, they take fascias with them. And these fascial adhesions, they were termed the masseteric ligaments, which actually have nothing to do with the masseter muscle. It's just a connection to the buccinator muscle. And here you can see the facial nerve branches. This is a marginal mandibular. It runs deep to the parotidomasseteric fascia. As it emerges from the parotid gland, it travels deep to the fascia, deep to the fascia, and at some point it pierces the fascia and inserts into the SMAS and to the muscle of facial expression. And when this change in plane occurs, this is what we call the masseteric ligaments. But actually, it's important to understand, it refers to the facial vein canal, it refers to facial adhesion when facial nerve branches change their planes. Next boost is the paramedian platysmal bands. The paramedian platysmal bands have been treated with toxins, but also with surgeries. But unfortunately, the surgery, which was did a very nice review on this one, is not as easy, because when they did the study and they reported on the long-term outcome, here's 1 year outcome, 1 year outcome of 96 patients, 35% said, yes, they still do have platysmal bands. 44% said, yes, they have skin laxity. Despite they did a very, very invasive neck surgery. They even transected all the platysma over here. But the results, as you can see, they were not very satisfactory. And at the moment, it's still very tricky to treat paramedian platysmal bands, because the problem with the paramedian platysmal bands, and this picture does not kind of really show the true origin. What it shows is actually you have these bands upon muscular contraction. But you also have these bands at rest, because due to skin laxity and platysmal laxity. And the location of contraction and of laxity is exactly the same. And this is what makes the surgical treatment so tricky, because you have both of things going on at the same location. And we currently working on a study which actually shows the reason why. This is a cross-sectional CT scan, and this shows the platysma. Here you can see the platysma. Here the platysma is contracted. Yes, a contracted platysma during CT scanning. I have very good co-authors on this. Here you can see the platysma, which is also called the superficial cervical fascia. And they connect down here and connect to the investing layer of the deep temporal fascia. Again, investing layer of the deep temporal fascia, and they have fascial connections. And when you contract your platysma, what happens is this area here is mobile because there's a layer of fat, as you can see this here, and it moves, all of this area moves, whereas this area does not move. So when you contract your platysma, you will have the first muscle fiber standing out, which are your paramedian platysmal bands. Because with increasing age, we lose volume, including muscles, including fat. This area here also becomes loose because it can glide. There's a gliding space here because there's fat. And when it can glide, it also prolapses anteriorly, and it causes the paramedian platysmal bands also at rest. So we have the same location, both for contracted and for relaxed, paramedially located. And this is how it looks like in one of my patients. This is the zone of adhesion of the superficial cervical fascia and the deep cervical fascia. And when I move, you can see all of this platysma here. It's movable, and exactly this is where we have the location of the paramedian platysmal bands. And it's just the fascial adhesion that we can see in this area. Next anatomy boost, ear reconstruction. Yes, I know it's very unusual of what I'm speaking in general, but it's very important. So boost number 5, ear reconstruction. Sometimes we have these problems, helical rim deflects, either due to trauma or even to basal cell carcinoma. And what you do actually so far, you do either a wedge resection or different other resection, and then how you want to reconstruct it. Either you take skin from the posterior auricular area, or you do Antia-Buch technique, or whatever, different techniques. However, all of these techniques are based on the idea that the blood supply comes from here and travels all the way down. It's radial blood supply. This is kind of the previous concept. However, what we did in the study is we cut all of this area and we did an advancement flap and then connected it, and that's it. The same here, a very, very long one. You just put it up, connect, and that's it. Why is this important and why does it work? Because of the blood supply. And the blood supply works because we have an arterial arcade running on the helical rim. It's an arterial arcade here that travels all the way down here from the earlobe up to this area here. And this arcade is called the Cotofana arcade. So when you do your transposition or advancement flap from here, you just take all the artery with you and connect it, and it's good. And you don't have to completely excise the ear, change the size of the auricle, and do different procedures. It's just you take this artery and take it up here, and that's all. And it works because you have this artery here, this one that connects the anterior superior auricular artery with the anterior inferior auricular artery. They all are connected, and you can imagine it works very well when you do incisions here and you advance them also. What also happens sometimes if people have a very loose earlobe and you inject fillers into this area, no problem. You have a very good anastomotic network here, also done by the Cotofana arcade. So it doesn't matter whatever you do with the earlobe, it always works. So no worries in this area, just go for it. Anatomy boost number 6, the deep temporal arteries. I know recently they gained a lot of popularity, these arteries, a very huge popularity, unfortunately, because of injection techniques with soft tissue fillers and because of the respective adverse events. When we dissect the temple and we advance the temporalis muscle, in this area here, we can see the arteries, how they emerge from the maxillary artery. So there's the anterior deep temporal, and there's the posterior deep temporal artery. So you can see kind of these areas here, they're located in this area. And then when you apply your deep injection techniques, especially with the one up and one over in this area, when you inject into here, you think you are safe because there's no artery. Kind of you just stay in this line. However, when you perform your dissections in this area and you look at this picture, you again could ask you, how can you inject deep and not hit one of the arteries? Because if you look at these number of arteries, there are plenty of them. And here again, you can see your anterior and posterior deep temporal artery. But the major problem with this one is, again, the connection to the ophthalmic artery circulation. Now you might ask yourself, how is that possible? How from here, the temple, we can get into the orbit? But unfortunately, Mother Nature made that possible. Because there's this artery here, and this artery is a branch of the anterior deep temporal artery, and this artery is called the zygomaticotemporal artery. It's this artery here. This is the anterior deep temporal artery, and this is the zygomaticotemporal artery. And when you look into detail in this one, you can see how this artery branches off. So there, deep down here in black, at some point there, if you go deeper, there you have your internal maxillary artery. The anterior deep temporal artery branches off. Here you can see temporalis muscle, here you can see buccal fat pad. And then here, this artery branches off and goes into the bone. And into the bone, it reaches the zygomaticotemporal foramen. And from here, you have very easy access into the orbit. because this artery connects to the lacrimal artery, and we know lacrimal artery is one of the branches of the ophthalmics. So we know kind of that this is the connection in this area, how you have a connection from the deep temporal into the orbit. And now, anatomy boost number 7, toxins first. Yes, of course, you might think, yes, I know this, I always do toxins first, or I do toxin first, and then I do soft tissue fillers. But now I will give you one reason why you should do this, especially in the glabella. When you do ultrasound of the glabella and you ask your patient to frown, then what you also do is you place some steri-strips, some structures into the folds that can generate a little bit of echoic shadow. You can see here one shadow, one shadow, one shadow. So there's midline, you have vertical glabella line here and vertical glabella line here, which corresponds to these 3 lines. When you contract, you can see that these ones here get closer, and then you can kind of see this formation. So far and up to date, everybody was thinking, and it was kind of currently accepted, that there's an artery deep to this vertical glabella line, especially the superficial branch of the glabella of the supratrochlear artery should be located exactly in that respective location. But this is not the case. You will see later on this year publication in the Aesthetic Surgery Journal, and there we described that the superficial branch of the supratrochlear artery is at rest 11 millimeters lateral to this, so which kind of means almost 1 centimeter and kind of in this location here, and in females 8 millimeters. Yes, of course, in females less because females have a smaller head in general. So that means the artery is not in the depth of the vertical glabella lines, not at all. But what is more important is the fact that the artery moves, and the artery moves from lateral to medial, because the soft tissues move, so the artery moves. And in general, the artery changes its position around 2 millimeters. Well, 1.6 in males and 1.8 in females, around 2 millimeters. So that means if you think in the glabella, you can predict the course of the artery, you always have to account for the contraction status of the muscle. Because if you have a very contracted glabella, you cannot predict the course of the artery. Even if you think it's kind of there, it's not, because the soft tissues are moving. And when you inject toxins first, you relax the soft tissues, the artery goes back to the original position where you can estimate the course of the artery, and then you can or might be able to increase safety during glabella injections. So this is a very important aspect, which I want you to understand, that arteries are mobile. Arteries can move together with the respective soft tissues. So when you do filler injections, you need to account for muscular status. This is one of the very important aspects that results from the fact, relax first the tissue, then you have native tissue without contraction, and then you can perform your injections. This is why toxins first. The other thing I'm very confident you know this about, and that's anatomy boost number 8. And it's one of the principles of soft tissue filler injections into the face, lateral face first. Most of you are familiar with the study, and this is a very important study which really shows why you should start lateral first. Because in this study, we injected the same injection points on both sides of the face, but with a different sequence. On one side, we injected medial first and then lateral. On the other side, we injected lateral first and then medial. And then we compared the amount of product that was needed in the medial face between one side and the other side. So we just compared the amount of product, how much is needed to have a symmetric outcome. If you inject medial first, you need significantly more product. If you inject lateral first, you need significantly less product. And this holds true for all the injection points. And the reason is because when you inject lateral first, then you precondition the midfacial soft tissues. You remember we talked about the layers of the face, the onion-like appearance in the lateral aspect. So this onion-like appearance results in the fact that you can pull on the tissues of the medial midface, you can precondition the midface, and then you need less amount of product, which results in more natural results, and which is also better for the patient because it's not that expensive. So I think this is the second principle of soft tissue filler injection after toxins first, lateral face first. And this is the paper that we published, and Gabriela is the first author on this one. The third principle of facial filler injections is upper face first. And that's my anatomy boost number 9 for today. Upper face first means when you start to plan your treatment algorithm for the face, you start in the upper face. Or if you don't start in the upper face, you start at least in the region above. For instance, if you want to do something in a jawline, you can go either the midface or you can go even up into the temple. And the reason is very easy, because if you use the temple, especially subdermally, you can utilize the fat compartments. You can utilize the fat compartments in a way that you can induce a lifting effect of this midface and even of the lower face. You can reduce all of this in kind of by placing the product into the right sequence. So that means if you inject into these areas here, into the upper face, you precondition the lower areas, but you also induce a lifting effect of the lower areas. And this is very important to understand, that it really matters how you inject, that you start lateral first, that you start in the upper face first. All of this matters because then you have a better outcome at some point later on. And this is a picture from the study we published 2 years ago, where we kind of injected into the temple, and you can see the resulting lifting effect is across the lower face and the midface. All of this kind of, you have effects here with jawline contouring, reduction in the marionette line, because you inject here. I know this is a little bit different, because why should you inject here? But this is, when you understand anatomy, you can really deduct and you can really treat your patients better. And we published this one as well. That's in the 2018 paper. And my last anatomy boost, what is more important, is know your rheology. This is one of the very, very important key facts for this area here. And by know rheology, I mean, you don't need to understand kind of what means G prime and G double prime. It might be good if you understand, but I know it's pretty complicated. I still don't understand it myself. But one thing that I want you to understand is that the G prime is not a constant. G prime changes of the product. And for this, we did a study. We tested a lot of products. We tested a total of 35 different soft tissue filler injections, and we tested them at different frequencies. And the frequencies can be done in rads per second, started by 0.1 and you go up to 100. And again, we tested 35 different soft tissue fillers. This is just an example. And you can see that the G prime here, the G prime, which initially at 0.1 rad is kind of located in this area here, it increases. G prime refers to the fact how elastic is a product. If you compress it, this product can come back to its original shape. You use high G prime products for the bone to mimic these deep plane volumizations. But what is important is if you have a low G prime product in this area here, and you subject it to a lot of frequency, then the G prime changes. The product becomes harder. And when do we have this? When do we have this in a face? So we have this in a face when we have a lot of mobility. And where is the area where we have a lot of mobility? It's the area where we have a lot of muscles of facial expression. And where is this? This is in the medial face. The line of ligaments, everything that's located medial to the line of ligaments is subject to a lot of movement, to a lot of frequent changes in the soft tissues. Lateral, here we don't have a lot of movement. Here, from here, really not a lot of changes. But here in this area, a lot of things changes, which can be reflected in a laboratory setting by increase in frequency. So that means if you think you inject a product with a low G prime in a high frequency area, the product will not stay the same. Just to give you some numbers, the change in G prime ranged from 48.5% to 3,000%. 3,000% in G prime. So that means a product becomes by the factor of 3,000% harder than you initially injected. Can you imagine what this means kind of when you inject this into an area where you want to have a lot of mobility? It will look unnatural. You can see the product. It will result in surface irregularities and in tissue irritation, which means the body that initially kind of should work very well with the product does not, because the product changes. It becomes much harder. It's like you think you inject water, but at some point you inject a stone, kind of theoretically speaking. And this is the thing, and this is how your body reacts. But this is why, I mean, you need to know your rheology. It's really important. And there are other products with the G double prime, which shows kind of how fluidy a product becomes. There are some products that decrease in G prime, G double prime. And there are also some products who also increase by 7,000% in G double prime. I mean, these are huge numbers, but I want you to understand that if you inject a filler, you need to take care of the area where you inject your filler. Because if you inject a filler into a high mobility area, you need to expect that the filler changes in its rheology. And this is very important, that you need to understand, know your rheology. And that was my last anatomy boost. And with this, we're done. Thank you very much for your attentions, my dears. So I'm going out of the share screen mode and I'm back with you guys. So Nicholas, I can see you. You just need to turn on your microphone. So he's on the phone. There we go.
No. I was trying to get my microphone on. So Sebastian, thank you so much. This is great things. I have a lot of questions for you.
Okay.
They are asking me here, what is the safe place to inject the nose and the lips?
Well, 100% safety cannot be guaranteed. That's point one. Point two is, for the nose, I would always recommend going deep in a supraperiosteal plane and to stay in the midline, because we know laterally, I mean, you know this much better than I do, laterally you have a branch that is the terminal branch of the anterior ethmoidal artery, which is on the lateral aspect. So this is why staying majorly in the midline and staying deep. You can use for this needles or cannulas, depending on the product that you want to use, but just stay deep. For the lips, it's different. On the lips, stay superficial, because the artery is deep. On the nose, the artery is superficial. On the lips, the artery is deep. So you always want to inject and place your products away from that respective arterial position. So on the lips, of course, the artery can vary, but in general, in most of the cases, it's deep. So what you do for the lips is you can either use a needle or a cannula, but as long as you stay superficial and you can see the tip of your needle of your cannula, you know that you are not inside the artery, and then you're totally fine.
Okay. Here they're asking, what do you think about aspiration with needles and with cannula?
Yes, that's a good point. I personally do not believe that it's possible to aspirate with a cannula, especially when it's primed. I don't think, because cannula is really tough to aspirate. But with needles, I think it is possible, but you need to have the correct product needle combination. You can imagine with a very soft product and a large diameter needle, you can aspirate very easily because the product will run through the needle back into the hub. And then when the product flows, you can always aspirate the blood with itself. On the other side, you just need to understand, when you have a very high G' product, it's very hard to inject. The extrusion force is very high, but if you want to pull it back, you need to get that product out of the needle and then to be able to aspirate blood. Now, I know it's very controversial, this blood aspiration, because there are a lot of false negative results. Either you can have a through and through phenomenon. That means you're through, but the product can still go into the artery. When you have a too high pullback volume and you are kind of like this, when you're inside the artery and you have a high pullback volume, you can compress the artery. And despite you're inside the artery, you cannot withdraw blood because it's collapsed. These are all factors that influence aspirations. And of course, the time. later this year, a paper will come out that will summarize 213 positive blood aspiration cases. And all of these 213 cases, which are a lot actually, who has ever had 213 aspiration cases? But what happens is that in all of the cases, blood was visible in the needle hub within less than 2 seconds. Because if you have the correct product needle combination and the proper amount of pullback volume, it will work. And it will work within less than 2 seconds. There are even some cases which where the blood was rushing into the needle hub without any aspiration. It happens because there's a pressure. And the reason why we know this and why this is novel is because this is the first study who looked at clinical cases, not at in vitro cases or laboratory settings. It's really clinical cases, which we summarized for this one.
Okay, great. Another one, where do you have to inject in the temporal space, supraperiosteal or superficial?
I personally would make it depending on the clinical indication. If your patient has just volume loss, then I would always recommend the anterior temple, and then I would choose between the interfascial technique or the subdermal technique. Mm-hmm. If you want to do and go in contact with the bone, I would go high up. And you remember we talked about this in a course which we had in Miami. You know, when you go very high up to the crest, you have a very nice lifting effect. And this is how you can place your product a little high up, which is much higher than the one up and one over. Another reason is because the diameter of the artery is smaller the higher you go up, and that's another thing. If you want to have for the temple lifting, I would always go subdermally, posteriorly, and place this bolus high up here in this area. So it depends on your clinical indication, but preferentially, I would stay subdermally, and then you're much safer because you're away from all of the arteries.
Okay. There's a question here about what you said in the glabella. So is it safer to do the injections in the glabella without frowning the muscles?
No, this is not what I said. So the thing is why we did the study is, I mean, the first thing we need to know, glabella is high risk zone number one for blindness, because dorsal nasal, supratrochlear, angular artery, all of them come together in the glabella. I personally would not touch the glabella unless with toxins, because if someone has wrinkles here, first do toxins, then wait for a while, and then really reevaluate if you really need to inject filler material. But if you want to really inject filler material, just be aware that the artery is somewhere else. And I tell you why we did the study, because everybody was saying the artery is right below the fold. Everybody was saying that. But this was leading to the assumption that if you inject next to the fold, the artery is not there. The artery is not next to the fold because everybody assumes the artery is in the fold. But this is not the case. We found out that the artery can be here, and we know that there are billions of other arteries, like the central retinal, central forehead artery, the paracentral artery. There are a lot of branches and anatomic connections between one side and the other. So this is why I do not make recommendations how to inject the glabella. I'm just telling you, if you want really, even if you have to inject the glabella, just be aware, do first the toxin and then wait for a while until everything is relaxed, and then estimate the course of the artery and then inject far away, preferentially intradermal and coming perpendicular to the respective fold.
Okay, here are two questions that are related. One is that if you can give the reference of the rheology study, and the other question is that what kind of product do you use in the temporal area?
So in terms of the first one, the paper is not published yet because the journals are working very slow these days because of something happened to the world during the last weeks and months. And the other thing is, it depends on what indication you have in your patient. If you want to have a resulting lifting effect of the mid and of the lower face, you just take a high G' product. a high G prime. The higher the G prime, the better. You can just inject it here posteriorly. If you want to have a volumizing effect here in the anterior temple, what you can do is you just use a product of medium G prime, not low G prime, a medium G prime that you can place subdermally, or you can still use a very high G prime product and apply the interfascial technique, coming from the forehead or coming from down here, the interfascial technique, and then you can take also high G prime product.
Okay. Well, that's it for questions. So Sebastian, I think we have answered the questions they send us.
Wonderful.
Thank you for a wonderful presentation. I think always to hear you speak about anatomy is a pleasure. And we're really grateful that you could be with us today. Hope to see you with us in a future time. And let's hope things are better for all the world and we can get back to work as soon as possible.
I hope so too. I really hope so too, guys. And I hope that, and I'm very, actually not I hope, I know every one of us will learn something. For everybody, it's different, the situation, but I think all of us will learn something. I think we're going to evolve much stronger from this. And I'm very happy to share my knowledge and to be here with you, and hope to see you soon at some of the meetings in the future.
A lot of commentaries that say, thank you, Sebastian, you rock, you're the great, you know what everybody tells you all the time.
Un placer. Thank you very much, guys.
Okay. Bueno,
okay, then see you next time. So, bye-bye.
Gracias por estar con nosotros.
Muchas gracias.
Esperamos que hayan disfrutado de este conversatorio. Les estaremos avisando para el próximo martes cuál es nuestro próximo conversatorio. Viene desde México, eso les puedo ir adelantando. Y bueno, pues muchas gracias a todos por estar acá con nosotros. Una feliz mañana, tarde, dependiendo de dónde estén. Hasta luego.